Hi, everybody. I am Dr. Rebecca Griffith, the ED-DPT. Welcome back to another episode of Admit It or Not, the ED-DPT podcast. We are going to be doing something a little bit different today, and I'm very excited to have these special guests with me who I will let introduce themselves. Dr. Patel, would you like to start?
Sure. Well, first of all, thank you, Rebecca, for the invite to join you on this podcast. And my name is Rupal Patel. I'm a faculty member in the School of Physical Therapy at Texas Women's University in Houston. And I'm one of the co-authors of this article that we're going to be talking about today.
Go ahead, Devon.
Hi, everyone. My name is Devon Morris. I'm a recent graduate of Ithaca College in upstate New York, and I'm here to give a little bit of a new grad perspective on this awesome article.
Hi, and I'm Terry Nordstrom. I'm an emeritus professor at Samuel Merritt University in Oakland, California, and one of the co-authors of the paper, like Dr. Patel. Dr. Patel and I are both members of the Physical Therapy Learning Institute board, which was kind of the source of and ideas that came out of the need to write this perspectives piece for the Physical Therapy Journal.
So I really appreciate you being here. I read this article, and correct me if I get the title wrong. Crises is the Crucible for Change in Physical Therapist Education that came out in PTJ earlier this year. And it just blew me away. So there were so many moments during this article where I had moments of like, holy cow, like that never occurred to me. I also had moments where I teared up because I learned something that was so impactful to me and so like eye-opening that it gave me like significant pause. And I'm like, I like getting teary just thinking about it now. So I wanted to really discuss this article with you. And while I'm not a physical therapist educator, per se, I do some lab work at different PT programs and I give guest lectures and things like that. But one of my favorite things to do and part of my vision for my career is to impact the lives of students. And so I want to talk first about why you decided to write this article.
Terry, you're the lead on this.
I can start. There were several of us. As you know, in basically the world started showing up in the clinic and in PT programs, right? With the onset of COVID and the pandemic and the way it suddenly impacted all the physical therapy education and practice. And almost simultaneously, all of the violence against people of color, especially Black people of color in the United States, happened, and has been happening, but it seemed to accelerate, and it just was like this, all of a sudden, this explosion, as it were, of how everything that we thought we could isolate from in our programs and in our clinics was showing up, whether you're in the classroom with students, whether you're in the clinic with students or whether you're in the clinic with patients and colleagues. And we said, we need to do something at the very core that causes us to pause and think and ask, how can we change? Because we often heard, oh, I can't wait for things to go back as they were, because we know they won't. That's my version. I don't know, Rupal, what you would have to add. But
Yeah, no, I think that's very well said. And Rebecca, I want to go back to what you said. And I think I said this to you in our DMs, but you are an educator. Every physical therapist is an educator. You're educating your patients. You're certainly educating students in the clinic. And so you are part of that education realm. And so, I think you reading this article and wanting to do something actionable by having us on your podcast is like awesome, because that's what we would want, as authors, to ignite others to kind of read it and say, what can I do within my realm regarding this crisis that we're having, and that what is that crucible for me for change, And so I think I would echo what Dr. Nordstrom said in terms of just, it was a time when it's like enough, there's so much going on and has been going on, but COVID certainly brought it to the limelight, in ways that, those of us that have been in this space is like, yeah. But now it's like, it's here and it's not going to go away, and it's only going to get worse. And we need to kind of put something out there that will make people think and will make people take pause, just like what you said it helped you do. And so I think that was, kind of the impetus for me being involved in it, and just to be on the same page with Dr. Nordstrom and some of the other folks is like, great. And I learned so much from the process of the writing that, that took us on a journey, I think, as a team as well.
So for people who haven't read the article, can one of you summarize it briefly so people have some context for what we're talking about?
Well, I'll try, because like you said, Rebecca, when you read it, it is complicated and complex, but in essence, what it's saying is that from the perspective of physical therapist education, you have to start at the very core, which is what's the foundation what's at the very root of the foundation of the program, and in terms of its mission, but in particular from this article, the curriculum. And what are your beliefs and values about the curriculum, and how and why you're teaching what you're teaching? And this article says, we have to go beyond content, and we have to even go beyond content and clinical thinking and reasoning and decision-making to the values and beliefs that our curricula are founded on, and that our profession is founded on. And that at our very core as a profession, we have a responsibility to continually improve society and the world in which we function. And this article asks, so what's going on in that society? How do we then design our curriculum based on core beliefs and values about change, and educating physical therapists to be advocates and change agents out in our communities to better meet our mission, our vision, as physical therapists, because we're all about movement, and people everywhere move. I mean, it's like, and people who are experiencing the most significant health inequities have the most impact on how they move about our society. And we said we have to look from that perspective. And that this article takes it from that perspective of the social determinants of health. Those are the biggest causes of health problems and illness and disease. We have to then be able to understand and affect those if we were to be effective in meeting our vision.
I can think of a moment when I was a student where it was clear to me.
Dr. Patel, you could probably add, but.
Yes, please go ahead.
Oh, no, go ahead, Rebecca. It's okay.
So there was a moment for me when I was a student, and I signed up to volunteer at the clinic for patients who were experiencing homelessness. And I thought, this is gonna be great. I'm gonna practice my skills. And at that time, like what I knew was like how to do range of motion testing, and like maybe how to do some gentle soft tissue, and like, here's how you should sleep with a pillow at night. Like these were the skills that I had. And my first patient sort of presented like this. And I was so pumped because I had all these ideas of how I was going to fix her neck. And when I went to touch her, she like literally like started hitting me. And it occurred to me that I was missing something. And it turned out that she had been a victim of some significant assault and violence involving kind of an asphyxiation event around her neck. And she gave me permission to share her story because we had a conversation about how impactful it was for me to realize that, like, it wasn't just range of motion, and that context was so important. And that was the first moment for me that I was clear that that range of motion and adjusting the pillow was not it, right? Like, that there was a lot missing. And that's what I saw here. And now, working in the emergency department, I see so many patients who have that context that we are missing when we're educating students in how to be a technician. And you guys talk about that a little bit with your skills of the habits of the head, hand, and heart. And for me, that in the emergency department, like, that got me. So can you speak to that a little bit?
Yeah, and I think, Devon, before we got online to the live podcast, you mentioned about, like, in terms of educating PT students, learning how do you fit in the habits of the heart, when the NPTE or others, maybe from your perspective, focuses more on the habits of the hand and other things. And so I think that's kind of the thing that, for me, as an educator, I would want to reframe for our institution, for our profession, for our department, is flipping that lens and, like, thinking about the habits of the heart being the crucial, vital things. And, like, one of the things in the article that Dr. Nordstrom was critical in writing about is just that, what is our it was a trustee, what did you call it, Terry? I forget.
Trustee institutions.
Yes, that, as educational institutions, higher educational institutions, we have this contract with society in terms of that we are producing people and, to change society, to make society better. And so that whole concept of social construction, reconstruction through education, and developing people's habits of the heart, along with the development of the other skills, because it's that habit of the heart, getting to that patient you talked about that had that episode, and exploring that is what's going to build trust, so that she will let you then put your hands on her, right? If you don't get there, if you don't start with the habits of the heart, you're not, as you said, you're not going to do that patient any service, and
just trauma, just a little extra side of trauma.
Yeah. So that's the thing, is like, and you're right. I feel like, as a profession, we kind of started with skills and knowledge and competency, and we've always thought about affect and heart and those things as fluff, as like things you cover when you have time, or in those courses with just credit. Soft skills, but they really are the hard skills, and I think as the next whole generation, the iGen, they digital natives, and maybe Devon, you're one of them, it's difficult, because so much of what they have grown up with has been right here, or maybe even in this forum. And so to be able to, give time to develop habits of the heart, and to do it in the curriculum, because they're going to be all healthcare providers engaging with people, I think is important. But it takes a flip, in terms of, for all of us as educators and professionals, to value that, and I think that's where there is disconnect, is the value proposition, the value we place on our trustee institution relationship with society.
Yeah.
Devon, what's been yours? Oh, go ahead. Sorry.
Go ahead. Oh, I was just going to say, that story you told, Rebecca, is absolutely perfect illustration of what the paper's about, right? And what we ought to be about, because you interacted with a patient where a lot of people would have made different decisions and reached different conclusions about what was happening with that patient.
Yes.
And you did, right? And you asked, what's going on here? And you let go of judgment and assumptions about what was going on there, to be able to look at, for me to do my best job as a physical therapist, I have to look behind the behavior that I'm seeing.
Yes.
And better understand this patient. And that's all we're suggesting we do, quote unquote, all.
Well, and I think that's it's very pertinent to emergency department practice, because many of our patients, if they had somewhere else to go, they would probably go there. If they weren't in significant distress, many of them wouldn't come here. If there were alternatives, like, and I probably say this on every podcast, but physical therapy should not be a luxury. And it should be something that everybody has access to. And in the emergency department, we can provide that. And we can take that moment to like step behind those contextual factors and take the time we have with the patient and provide them the care, the best care that we can in the moment. But so much of what we do is really sorting through that. So that I think that's part of why this article resonated with me so much, because if you don't have the habits of heart, you can't practice in this setting. And I think any emergency department PT who's listening to this is nodding their head. Like, that's so much of what we do. I often have physicians say, or I'll say, I'm not that kind of therapist. Like, they need other things. But the response is often like, but you're the thing that we have that's closest to that. And you're the one that can sort through some of those things. And luckily we have a whole team that can help. But so many patients don't have access to that. And in a little bit, I'd like to talk about social determinants of health and how we sort through some of that to help serve our patients better. But Devon, I'd really like to hear from you about your experience as a PT student with some of this like concept around the head, hand, and heart. Because I know for me, students in the clinic tend to get very caught up on what their hands are doing. And I find it much harder to teach the habits of the heart than I do to teach them the hand and the head. And so from your perspective, what do you think are the best ways to learn this? And are you learning that? And are you seeing that change?
Yeah, so, I'm very fortunate to have attended a very progressive thinking DPT program. Ithaca, had very specific classes like teaching and learning in the clinical setting, teaching you how to mirror a patient's body language, help them feel more comfortable. We had psychosocial aspects of care in our final year, and we had guest speakers come in to tell us about their lived experiences, guest patients, basically, previous patients, tell us about their lived experiences, what they, appreciated and wished was different with the therapist they had worked with. And so I've taken that with me to my rotations and my events, like at the national level, where I've engaged with other students and clinicians. And I see that that's not something that all programs do. One example comes to mind, like my first rotation of physical therapists I was working with there made a joke to an African-American man, when he took his shoe off because she was about to work on his ankle. And she was like, "I hope your foot doesn't stink. Like, I hope you showered today," like something like that, like just like joking. And she was white, and he kind of shoved it off, but then he called the clinic back and let her know that, that's not something that you should say to someone, because you don't know whether or not they are homeless and haven't been able to have a shower. You don't know anything about what they actually might have going on and what that might trigger. And so that was an experience that I've held with me because that showed me that she didn't learn the soft skills that she needed while she was in her PT school. So I'm really happy that it highlights, I love the quote, developing those habits of the heart is when students become physical therapists. And, when you finally put it together and realize, and when the skills become second nature, and then what's really important is how you connect with your patients, because it doesn't matter how good you are, it doesn't matter how many letters you have behind your name. If a patient doesn't trust you or believe in you or want to work with you, how are you going to help them? So that's been my experience so far. I'm really happy that we're talking about this paper, because I think it's really important for every single program to see. It makes me really happy that I'm able to check off some of these things that I learned from Ithaca. So shout out, IC.
I love that. I think you touched on a little bit about kind of issues around patients who might be being served by a white physical therapist. And I was reading this article, And in my immense white privilege, when I read the sentence that said, given that 76% of physical therapists identify as white. And I thought about that for a minute. I was like, oh, I've never noticed that. And like what a privileged place to be, right? Like that I hadn't noticed that, but I assure you 76% of my patients are not. And I have taken that statistic and really started to approach my patients a little bit differently, and not just assuming they want me to put my hands on them, and not just assuming that what I'm saying is meaningful or important to them, regardless of who they are, what background, what culture they might be from. Because I see many patients who don't speak English. I see many patients who are fleeing from other countries. And just like that patient who had the domestic violence assault, like I need to take that moment to establish trust before I put my hands on my patient, and just be aware that there is like true harm that has been caused to so many patients by people who look like me. And that was eye-opening for me as well, to like really realize that. And so I've taken a little bit different approach with my patients by asking them, what has no one asked you that we should be asking you? And what is no one hearing from you? Or what concerns of yours have been dismissed? And let's start there, and tell me what you need from me and what your ideal outcome looks like here. And before I touch people, I say, may I have your permission to touch you? Or would you like to do this while I guide you? Things like that. So I'm just wondering what other suggestions all of you might have to approach that from a more mindful perspective, especially in the setting of the APTA having our motion regarding becoming an anti-racist organization. That really helped me tremendously as well, to see that there was so much more that needed to be done and could be done. And what are best strategies as a clinician and an educator to be more mindful and appropriate from that perspective?
Well, I think the examples you just described are perfect examples of habits of the heart. The questions or the open invitation to conversation that you're allowing your patients. I mean, that's what's needed from, I think, to develop those skills. And I think, from, again, an academic standpoint, a clinical standpoint, I think clinically role modeling those behaviors for your students is powerful, because I can sit here in my ivory tower of academia and talk about those things with my students, or give them some opportunities to explore that, have patients come in like Ithaca does, and talk about that. But if the student gets out in the clinic and they don't see the behavior that they were taught, the knowledge and skills actually emulated, then their own, whether it's their own self-confidence, efficacy, or belief in it, kind of diminishes. And unless they just have a very strong sense of being in that social justice or social change space, then maybe not, So I think for me, to cultivate habits of the heart and some of the things we're talking about, having clinicians emulate it like yourself is key and is important.
Yeah, I would add, I mean, those are also those, I appreciated those examples as well. And I think the thing that comes to my mind is to ask questions to better understand the person's living situation before you dive into what they're going to be doing at home, right? Because not everyone has a safe space to walk. Not everyone has a safe space to lie down in bed, or even a bed, right? So to ask questions to better to know what are the possibilities and where are the limitations before I start going through, here's your home exercises. And I think back many, many times, like about probably close to 100%, where I didn't do that in practice, right? I just said, okay, so lay in your bed and do these exercises without even thinking that the person may not have that as a possibility. So I think those kind of questions are absolutely crucial if we're going to be effective at that level of that individual patient.
One example I can think of to illustrate that was a patient who was presenting with some low back pain issues, and she had endorsed incontinence to the physician, but with further history receiving from that patient, it really was clear to me that, and with the patient helped me understand. She wasn't truly incontinent. She was recently had lost her home and was living in her car, and she didn't feel safe going to the bathroom anywhere. So she was actually just going to the bathroom where she was in her car because she was too afraid to leave the car at night. She didn't have a safe place to go to the bathroom. She wasn't sure really how to manage that. So that's like, that is a critical piece of medical information right there, like from so many different levels. But is this patient likely having spinal cord compression? No, probably not, because it is a volitional thing related to her circumstances. And that's something we could help her with. But did she need an MRI for that? Probably not. And we were able to work through what the changes in her back pain had been based on the time she had been living in the car, and what could I do to make that circumstance better for her, in addition to meeting her where she was at and not saying you should go sleep at a shelter and all those problems would be fixed. That was not a solution for this patient. So really trying to understand those things for the patient, I think, like you say, is absolutely critical, particularly in the emergency department. Devon, what are your thoughts?
Yeah, I think that was right on the money, honestly. And, fellow students will commonly ask me, I had this interaction with my CI, and they said this to a patient and made me really uncomfortable. Is there anything that you would have said differently, or do you have any recommendations for things that I could have said? Or even with patient interactions. And, people are socially awkward when they're trying to run through all of the anatomy in their brain at the same time while trying to communicate. So I started thinking about is there, we have standardized feedback for certain outcome measures so that, a performance isn't biased. So is there something that could be standardized, like bare minimum, that we can, like a framework or something that will make it easier to give, incoming therapists something to go off of, so that they're at least not having their biases influence how they communicate with patients. So that was one of my questions as I was reading through this. Not necessarily for like a solution, but where can we start? Like, where's someplace small that we can start? And of course, not everything is going to be perfectly said. And there's so many different variations of how things could be said. But, even like training, and I'm thinking back to my teaching and learning course, even with just like learning how to do appropriate body language for certain things. Like, can we teach tone? Can we continue to teach the body language that matches the words that we say? And, a little bit of fake it so you make it until it just starts to come naturally. And, that's one way to check biases, because everyone has some type of bias or unconscious bias. And so that we stop before we get there. I kind of went on a trail there.
I love that. But one thing that comes to mind for me when you say that is, as an experienced clinician who did not have this as part of my education, how do we get continued education and continued competence in this area? Like, what are resources for that? And how do we improve in that area? Because I think so many PTs are like, well, I don't need that. I'm a good PT. I know what I'm doing. Or if I try, I'm going to do it wrong. So I'm just going to be myself and people can just deal with it. Like, I hear that a lot too, that PTs are too afraid to try, that they're going to offend somebody or upset somebody or make it worse. And so it's the other person's problem and not their problem. But I'm going to challenge us to make it our problem. But how do we do that? How do we improve, and how do we get better? And how do we, what are the next steps for somebody like me who's been practicing for 14 years and wants to be better?
Yeah. I mean, as I'm listening, I'm reflecting back. I did the Pauly Sarasoli lecture in 2018. Was it 20? Anyway, I had the privilege, as part of that, I talked to Zach Rethorn about some of his experiences. because he was in a clinic in I believe it was somewhere in Tennessee. Stop there. Underserved people. Patients weren't getting better. Went to a residency program thinking this is going to help. Comes back from the residency program, patients still not getting better. It was only when he looked behind their clinical problems into their social systems and structures that he began to understand this is how I'm going to get my patients better, by better understanding what's going on behind the signs, symptoms, et cetera. And so I guess when you ask that question, I'm thinking it's that kind of attitude that says, yes, I have to get better at being the core skills of physical therapists, whatever that is, in whatever area of practice. But at the same time, I need to get beyond that core of physical therapy, because behind that is everything else, who these people are in their lived experiences. And to me, that gets to the social determinants of health. And you have to ask questions about those social determinants of health. And you can't stop at just asking the questions about them. You have to have a resource, as it were, to refer people to when you uncover that, oh, I'm about to lose my house because I've got this eviction notice. Well, you have to know who are the resources in my community to help someone on the legal aid side. Now, many emergency departments have those resources, but many don't. I venture to guess that many physical therapy clinics may not have those resources, but they're there. And I don't think we referenced this paper in this paper we're talking about today, but 2017, Burgoy, Burgois, and Holmes published an article in Academic Medicine on a structural vulnerability assessment tool designed for emergency departments. I think it was 12 to 13 very straightforward questions going through every one of the elements of the social determinants, transportation, housing, et cetera, food, and asked a simple question. And to me, boy, oh boy, if we expand our thinking and where we're looking for education into those areas, then we're going to go a long way at being better at being physical therapists.
I think it's important to consider those issues as well for our students when we're thinking about social determinants of health and how they also impact our students, because not every student is coming from the same background. Not every student is coming from the same resources. And I recently experienced that with a student of mine who was about to lose their housing and didn't have access to the care that they needed for other related issues. And as a clinical instructor, I think we need to be mindful of that as well, because I know I have been guilty of extending grace to my patients and learning more and more about my patients, but sometimes I catch myself not giving those students that benefit of the doubt, not taking that time to really dig into the students' context and life around them. And I think some people would argue that it's unprofessional to do that. So I'm counting on you guys to dispel those myths for me. And Devon, you might have a firsthand perspective of that. How do we connect with our students, support our students, know our students, and how can we dispel that myth that it's unprofessional to do that?
Well, this reminds me of why I chose to come work at my current rotation with Doc J Physical Therapy, because, this article talks about being courageous and, not afraid to go against the status quo. And, when we are courageous in the usual PT setting, we are reprimanded for it and we get fired from those settings. And, Doc J allowed me to share her story, but, that's why she started her own practice, so that she could build really strong connections with her patients and her staff and her students and create, just a super healthy, happy environment that's healing for patients. And, this has by far been my favorite. And I have learned a lot about myself and about PT and about what it means to be a good physical therapist. And, it's tough because you want to do all of the things that this article tell you to do, but the systems don't allow it. If you still want to take care of yourself, I mean, you could go and do all of this. I could go and do this right now, and I would end up probably losing, burning some bridges and losing a couple of positions here and there. But it's tough, and it's deeply rooted, which is the issue. So how do we uproot it, or how do we get at the core concern? It's so many questions from this article. Very
Yeah,
tough.
and, I think you're just hitting the nail right there, because and it's not any one single solution, right? I mean, with any change that we want to see, we want to kind of want to look at what are the layers, what are the levels of influence, and you want to be able to impact change at multiple levels of influence, right? And so, Doc J, yourself, at the individual level, at the community level, at leaving a system and starting your own system, that those are ways to change. And then certainly at the academic or institutional level, there's change that can happen. And I want to go back to kind of what you were saying, Devon, about like the the whole communication aspect and teaching and learning of that. And I think in our article, we mentioned the concept of relational coordination. And I think in one of our tables, we actually define it, in terms of, and I think it comes from sociology literature, from what I recall. And we had a keynote address, was it 2 years ago? At the Educational Leadership Conference, with a person outside of physical therapy, but who's in this space of relational coordination, that talked about that, and I think bringing stuff like that into PT academia is important, kind of getting out of our silos and looking to other disciplines, other professions, in terms of how is this taught, how is this practiced, so that we can be better relational coordinators ourselves. So I think that is something that we need to do in academics better, and looking at that. And I think your point, Rebecca, about like clinically, where do you go to find continuing education for things that you didn't learn as an experienced clinician? So I think I'm seeing a little bit more of that when we go to CSM and other things. But I think that is something that the other aspect of it is, are clinicians valuing it? Because I think when you have a finite budget and time, in terms of money and time, to go to a continuing education course, do you focus it on improving your habits of the hand or habits of the heart or habits of the head, right? And again, we still have this mindset after being 100 years old as a profession to still be kind of the habits of the hand focus, right? And so I think, again, that's a shift, and more of us that are in this space making that change, then that kind of hopefully snowballs into change. And then last thing I'll say is, going back to what Terry said about, it's not just important to screen, but to then address, and I think that's so important for students to understand, and for clinicians, because, we lost Devon. Hopefully she'll come back.
Devon, she'll come back.
Yeah. But, the whole concept of like, patients get fatigued just being asked the same dang questions over and over again about their social determinants by all these providers, because it's on our checklist to ask the question. Because now everyone, systemically, from, Medicare, if you're ACO, whatnot, it's required that you look at social determinants. So we all ask it, but then if you don't address it, then you're actually doing a disservice, right? And so, one of the things in a different related I think it was a CSM session that I was involved with, we talked about was that in any clinical setting, there's this great findhelp.org is one of the sites I use quite frequently. And I put it in the chat so you can include it in your show notes, Rebecca. But, where you punch in your zip code and then you punch in what is it the patient needs. They don't have housing. They have trouble paying electricity. They don't have water. whatnot. And there's like resources with closest to your zip code, and it's listed by distance. They have food insecurity where you can then plug them in. So certainly if you're in a hospital setting in the ED, you may have social work or other departments designated to do that. But in other cases, you may be it, in outpatient or where you are with Doc J, and so just not just asking the question, but then having that resource. And I think sometimes I hear from clinicians and students like, Dr. Patel, when do we have time to do this? We see patients 8 hours a day. We document on our own time. Like, where are we supposed to go find that information? So it's not hard to find, and that findhelp.org could be a starting place for ED departments or others where you may not know where to go for that.
Yeah.
I think in one case, we are actually privileged in the emergency department because we can have help, at least at the department that I'm in. I do have a social worker. I do have behavioral health evaluators. I do have a case management team. There's even a team of patient navigators, we call them, that will help connect people to follow-up appointments. If they don't have insurance, then we'll find somebody who will see them. If we don't have equipment, we'll do our best to get it for them. So in some ways, that's like why we're there, because we are that safety net. And we are able to provide those resources. But I do agree that there are going to be clinicians listening to this, like saying, hey, there's no time for that.
Yeah. I'm thinking too on what I heard Devon talk about earlier about how it can be really emotionally taxing and discouraging to know what needs to be done, to have the courage to do it and make a decision. Do I have the energy right now or not? And I think it's where anyone in practice who also is a leader has a responsibility, not only like Dr. Patel was talking about in terms of relational coordination, but I think in terms of the whole concept of creating psychologically safe spaces in which we work and function, right? And to me, that means be vulnerable, admit when you don't know or make a mistake, which perhaps begins to open the door for the people who see things differently than you do, who can bring those changes about. So if you kind of let go of our attachment to the way things are, or the way things have been, or who I am and my ego, and to say, I'm sorry, I let my ego get in the way there, right? I got defensive. That kind of behavior can open the door for people that see things differently and perhaps can diminish the burden and the injury and the stress that comes along with doing that kind of work.
I like that. Any final thoughts?
Well, I sure appreciate you doing this, Rebecca. It's been great fun.
Oh, good. I'm like honored to have all of you here with me. And I just, if no one has any other thoughts, I want to close with the quote that closes in the article, if that's okay with you guys. So this is a quote from Dr. Geneva Johnson, and it really was meaningful to me. I highlighted it, I circled it. We hold the power within our heads, hands, and hearts to be whatever we dream. The horizons have no limits for us as physical therapists. We can create our future in spite of what may be to be insurmountable obstacles at any given time. And so I would encourage anybody who's listening or anybody who's thinking about making changes that we can surmount those obstacles. In Colorado, we hike 14ers all the time. And I think about this a little bit like a 14er, like the healthcare system and our society at large is a 14er. And the only way to surmount that is to get your equipment, get your tools, pack appropriately, and start hiking. So let's hike together and see if we can get over some of these obstacles and improve care for our patients, both in the emergency department and out of it, hopefully so that fewer patients have to come to the emergency department. And we can just make things better for our students, for our colleagues, and especially for our patients as we work together to transform society. And with that, we'll go ahead and wrap up. We'll have more information for you in the blog this week, as well as the resources that were mentioned on the show and more takeaways from the article, as well as all of the information you need to access this amazing article. which was Crises as the Crucible for Change in Physical Therapist Education. And if you haven't already, please like and subscribe to our podcast, and we will see you next time. Thank you.